Before then, I would like to introduce you to the UK's leading ALK expert, Professor Popat. He's also a world-renowned speaker and expert in ALK positive lung cancer. So I'm going to leave any more introductions to him. So if we could all put our hands together for Professor Popat.
So Deborah, thanks very much. And colleagues, friends, it's really lovely to be here and say a few words. Deborah said to me about this time last year, I think, will you come again and will you say a few words after dinner? I said, yeah, sure, not a problem. What do you want me to talk about? And she said, we'll have the same again. I said, well, you can't have me saying the same again, so I'll say something slightly different this year. So for those of you that don't know me, I'm a medical oncologist based at the Marsden in London. I've been treating patients with lung cancer since I had black hair, which is clearly mostly gone, but at least I've got some hair, so that's not a bad thing. So some of you will have seen me hanging around the lobby most of the afternoon. And that's not because I haven't got a home or I've been booted out by my wife. It's because I flew in and I've spent the last few days in Korea. The Koreans had a meeting and I was giving a talk there. And it so happened that one of the university that I am on the faculty of, the Institute of Cancer Research, the head of their therapeutics division, a chap called Paul Workman, was there. And I was chatting to Paul, and Paul designs drugs for a living. And we were talking about how you design a drug, how do you make it work? How do you take a chemical and then make it into a drug? And he reminded me of an amazing tablet that he was involved with, a tablet called gefitinib. And gefitinib actually was a really interesting tablet because it was a tablet we started to use in the early 2000s. At that time, lung cancer could only be treated with chemotherapy, and there really wasn't a lot of interest in treating with chemotherapy because chemotherapy was a really difficult treatment at that time. And he designed a tablet called gefitinib, and it started to be used in a few places in the US. And when we gave it to a few people, it didn't really work, but we gave it to a few other people and they had really quite bizarre, remarkable shrinkage. It was like you were getting rid of an infection in the lungs like an antibiotic over a course of 3 days. It was really quite remarkable and nobody could really figure out why this tablet was working. We knew that the tablet would work a bit more frequently in females. We knew that it seemed to work a bit more frequently in patients from East Asia. And we knew that it seemed to work a bit more frequently in patients with a particular type of lung cancer called adenocarcinoma, but we didn't really figure out why. And it got an approval, even though it was a bit hit and miss as to whether it would work dramatically or not at all. And it was a really straightforward tablet. And then we did an experiment where we took several hundred patients. Half of them we gave the tablet to, and half of the patients we didn't. And the outcomes were exactly the same. And the FDA said, well, your tablet's rubbish. We're going to take it off the market. It doesn't work. And everybody was up in arms saying, yeah, but it may not work in the majority, right? But actually in the handful of people, it makes a remarkable difference. And they withdrew it. So the tablet just simply was not available for actually quite a few years. And then in 2004, a couple of groups that were running science labs in Boston, in direct competition with one another, by the way, identified something called EGFR mutation, and that's 20 years ago this year. And what that science showed is if your tumor had something called an EGFR mutation, then that tablet, gefitinib, would work really well. And if your tumor did not have an EGFR mutation, that tablet would not work at all. And that was the first example of what we call precision medicine in lung cancer. The first example about how we should be taking a patient's tumor, understanding the science, not just calling it a lung cancer, but understanding the molecular structure of the tumor to help us work out which medicines will work on that cancer and which medicines is a total waste of time and you shouldn't really be bothering with. And that was 20 years ago. A lot has gone on in that last 20 years, right? So in 2004, EGFR mutations were identified. In 2007, 3 years later, a Japanese group of scientists were looking at some cells in the Petri dish, and they had cells from a Japanese smoker. And they were looking at his cancer cells in the Petri dish, and they found a unique abnormality which had only been identified several years earlier in a cancer called lymphoma. And they found this strange abnormality in this Japanese smoker's cells. And this abnormality was in a gene called ALK, and they found that the ALK gene had moved to another place in the genome where it shouldn't be, and had fused with something else, and they called that an ALK fusion. And that was published in a journal called Nature in 2007. And what was really amazing was that Pfizer, the large company that you all know and love, had a drug that they were developing at the time, a tablet. Not one that my colleague Paul had worked on, but their scientists. And it was a chemical. It wasn't even a drug, right? It was a chemical. It had a code name, PF02341066, and I remember it well because we did the experiments on it. And you had to remember this number, and you had to give this 20-page booklet to a patient and trying to go through that. It didn't even have a name. And this drug was developed not for ALK, but it was developed for a type of biology called MET, M-E-T, which is another abnormality that occurs in cancer cells. But they knew that PF02341066 was also very good at switching off ALK, but they didn't know how to find these patients. And so in 2007, Pfizer then worked with a group in the US at the Massachusetts General Hospital, and they worked out a test where you could take a patient's tumor and then you could do a test on the tumor to tell you whether it's ALK positive or not. Because in 2007, we didn't even know how to test a patient's tumor to know whether it's ALK positive or not. So suddenly, at the end of 2007, beginning of 2008, we were able to test people's tumors to say whether it's ALK positive or not. They found somebody that's ALK positive, and Pfizer said, yeah, let's give them this tablet. And they gave them that tablet, and the patient got remarkably better within 3 days, exactly like the gefitinib example 3 years prior. So Pfizer said, forget this, we're not going to follow MET, let's just find ALK positive patients and treat them with PF02341066, which the WHO then gave its name, crizotinib. And that was the birth of crizotinib through a very serendipitous happenstance of fortune that Pfizer happened to be having a drug in development at the time that ALK biology became to be understood. And a lot has gone on since then. We first knew that crizotinib was active in about 2008, 2009. We started testing it, I remember doing the first experiments in about 2009 in the phase 1 and phase 2 trials. In 2010, we had the first published documentation that patients were really having really very good responses. And much, much, much later, the NHS finally, eventually gave approval in 2013. That's when we first had full NHS approval, although we could access it a bit earlier. And then the biology of ALK has really hugely changed incredibly quickly over that period of time. Having had all this experience in crizotinib and ALK-positive patients, I was invited in 2012 by the European Society to be the expert discussant commentator on 3 new drugs which were in development. There weren't drugs at that time. Again, they were chemicals. They'd only been tested on about 20 patients. One of them was called LDK378, went on to have the name ceritinib by Novartis. One of them was AP26113, which you will know as brigatinib. And the other one is an incredibly long one, CH424802. CH stands for Chugai, which is a Japanese company. And that drug is called alectinib. And I was discussing these data sets with about 20 patients treated in each of these trials. The entire room was full, and there must have been about 10,000 people, 10,000 oncologists in that room. They all piled in. We heard the data. I gave them my view on it, and they all piled out again. And then whoever was talking next about some other drug, nobody was interested at all, because everybody was there to hear about ALK and the huge advances that were going on in ALK positive disease. And in a very rapid, short sequence of time, we've gone from crizotinib to ceritinib to alectinib, brigatinib to lorlatinib, and then now we're moving to potentially using lorlatinib up front as the first-line treatment. So we've gone a huge, huge way along the last 25 years or so in our advances in therapeutics and our understanding of the biology of lung cancer and our understanding of the biology of ALK-positive lung cancer. And Deborah, I was sort of thinking, well, what have I learned, right, over the years? What have I really learned from this great experience? There's quite a few lessons that I've learned. So the first thing is actually listen to your patient, because actually your patient will tell you exactly what is going on, not the scan, not the nurse, not your registrar, not the clinic nurse who preps you before you come in. Listen to the patient and listen yourself, right? Don't, listen via other people, because actually everything that you say reflects what's going on in some aspect of the treatment that we have to think about. And this is incredibly important when you're dealing with new drugs, new conditions. So when ALK-positive lung cancer was first discovered as a disease entity, we didn't really know anything about it, right? We just thought it's another form of cancer. But actually, ALK-positive lung cancer behaves in its own unique manner. We see people who have tablets and develop vision problems. We see people who develop blood pressure issues. We see people who develop cholesterol issues. We see people who develop weight gain. We see people whose testosterone levels are extremely low. We see people who develop blood clots. We see people who develop cysts in the brain. We see people who develop cysts in the liver. We never knew any of this before. We've had to learn it. We've had to learn it together as you take the medicines, as we observe what's going on. As we listen to you, you tell us what's going on. And we can then share that information. We wrote many papers about how, for example, testosterone levels go down with crizotinib, how you have a lot of bulk in the lungs, and sometimes the lungs can burst because the cancer shrinks down so rapidly, how you can get many other complications, what to look out for, the issues around blood clots. The second important lesson that I learned is we have a secret weapon, actually, a secret weapon that I didn't really appreciate until 2017. And that secret weapon is all of you, actually, because I think patients are actually the secret weapon that we have as the healthcare workforce. Because let me tell you, nobody listens to doctors at all. Nobody gives a monkeys what we say. Nobody gives a monkeys what the nurses say, frankly. The administrators will do what they want to do. Government will do what they want to do. But you got one vocal patient there with an emotive story. Boy, policy changes overnight. It's like a clinical trial. I can treat 10,000 patients and tell you exactly what goes on. You're not interested in that. You want to know that story about the one individual. It's exactly the same. And that's why all of you in this room are actually the most important thing that you've got going on for the group. Because as a group, you are incredibly powerful as what you can do, as what you can achieve. I think, Deborah, I saw somewhere the strap line, support, empower, and advocate, right? And nothing, I think, is more important than those three words, because actually what you've done with those three words, I don't think any group of physicians or nurses could have done at all. And I remember when I started treating lung cancer and ALK-positive lung cancer, we were routinely telling people about the rules about brain and driving at the time with the DVLA. But the work that you and your group have done to change the rules that the DVLA have, I think have been really quite incredible, actually. And I really look up to you very highly with the work that you've done there. And all of you, because without your support, the charity cannot move forward and drive the changes in policy in healthcare and algorithms that we use in routine clinical care. And only with your support can we work out the best standards of treatment and disseminate those best standards of treatment throughout the UK to try and ensure that whether you're seen in the smallest hospital with the rarest population or a busy practice where we see outpatients every day, you're getting exactly the same standards of care. So the third lesson I've learnt is that research is the key to success, actually. It's not just good luck. It's not just fortune. It's not just serendipity. Things don't just happen. Actually, it's scientific research. And I can tell you that because I do a lot of it. And the advances that I've seen with scientific research, we are seeing in this room today. Because the story of how we have taken a disease which was undruggable and transformed the outcomes of the patients that I see and treat now compared to when I was seeing and treating lung cancer back in the mid-1990s are totally different. And that can only occur through the implementation of research. We've seen huge shifts in how we treat cancer in the 10 to 20 year period of time. When I started treating cancer, all we had up our sleeve was chemotherapy. Chemotherapy is great. It can work wonders for some patients, but it's tough. And nobody wants chemo unless you really need it. Since the era of chemotherapy in the early 2000s, we've had the era of genomics, where I remember watching the news and there was whoopee because the human genome had been cloned or was sequenced. And I thought, yeah, that's brilliant. I mean, that's not going to change my life tomorrow, but actually it has changed our life 10 years later because we understand what the normal human genome is that allows us to understand what's going wrong in the cancer. And if we can understand what's going wrong in the cancer, we can then put the right drugs on for it. We've then moved from the genomic era to the tablet era, where we've got these new tablets called kinase inhibitors. And we've even got a new version of kinase inhibitors. You'll hear this term that we use called macrocyclic TKIs. The macrocyclic drugs are the new generation of TKIs that we're very interested in. And we've moved through new generations of drugs. We're now looking at things called immunotherapy. It doesn't work in everybody, tends not to work in ALK positive lung cancer, but there are new generations of immunotherapy coming through, which may or not work in this disease. We've got a whole new draft of drugs coming through that most people have never even used in routine clinical practice, called antibody drug conjugates, ADCs. These are very exciting. Some people say they're just like delivering chemotherapy in a very complex manner, but sometimes they work incredibly well, and they perhaps may work very well in ALK positive cancer. We've got vaccines coming through, and the UK, I think, is in the forefront of vaccine delivery. We have, in our health sciences sector, signed big deals with Moderna and BioNTech to deliver their vaccine pipelines. And there's going to be a lot of vaccine development in cancer over the course of the next 2 years. You're going to hear a lot about personalized vaccines. And the new kid on the block is something called PROTAC drugs. There's a big article last week about PROTACs. And these are tablets which are used to change the biology of certain cancers. So we've got a lot to be grateful for. We've come a huge way from where we started, and there's a lot that's going to happen over the course of the next few years. But we've got to reflect, actually, because each of us are here standing on the shoulders of what I call giants. And who are the giants? They're people like you and I. There are patients who've come before us and said, yeah, I'm going to put my hand up. I'm going to take part in a clinical trial. I'm going to be part of that experiment. I'm going to say, yeah, I'll, take this tablet. We're not sure whether it's going to work or not. I have no idea. But if you think it's a good idea, let's go for it. And it's only through that selfless participation in a clinical trial can we capture that data, can we understand what's going on, can we move that field forward. And I think we should really be very grateful for each and every one of us that's participated in some sort of research, because every research endeavour counts. Perhaps the fourth and final thing I've learnt is everyone's cancer journey is different, totally unique, totally different. We see this day in, day out as oncologists, as nurses, as cancer specialists. The details are actually quite different. The themes may be quite common. And on the outside, it can look brilliant. It can look like the swans sailing on the surface, floating away. Everybody's great. But believe me, every single patient is struggling beneath the water at some stage of their journey. And with experience comes the ability to spot these issues, spot the problems, try and prevent the problems, and know where we're going to see problems starting to come up. And each individual journey is slightly different in some sort of way. And one of the things that we've also learned is that we have patients that not only do incredibly well, but we have patients who have ALK-positive disease and have extremely aggressive disease. And for reasons that we don't understand, driven really by the biology, I think, that their disease is not sensitive to ALK inhibitors and they have very aggressive disease. We should always remember those patients because they're not in this room, because they're too sick to come to meetings like this. So look, what does the future hold? Where are we going with this type of disease? Have we reached a plateau? Is there going to be anything more? Well, you know what? I'm incredibly excited, right? I think there's a lot going on in the world of cancer therapeutics in general, and certainly in the field of ALK-positive lung cancer. The next 48 hours, just speaking to Deborah, you've got the most amazing speakers in the UK, and even one from Australia dialing in. You've got some of the UK leaders talking about all aspects of lung cancer care and ALK-positive cancer, all the things that are relevant. We've got new drugs coming through, and the world of drug development is changing so quickly at a scale. It's never been as quick the scale as we've seen so far. For example, we now have lots and lots of ALK inhibitors being developed in China. China biotech industry is absolutely massive. If you look east and look at what is coming out of China biotech industry, it is going to revolutionize, I think, where we are with our usually Western biotech development. In fact, many of the drugs that are coming through are making an impact and being licensed in China first, and then are being picked up by Western pharma, piggybacked along, licensed in the West, and then developed further, and then about 3 years later get an approval to use in the West. So one of the things I always say to the juniors is keep an eye on what's going on in China, because there's some very interesting drugs being developed. We're going to hear about a new drug being developed called NVL-655. I don't think it's got a name yet. May not do. We'll find out. It's a very exciting drug. It's in trial development in at least 2 centres in the UK. And there's a lot to learn about that drug. And the future is also quite interesting because there's a whole new group of ALK-positive patients coming through. These are patients who have operable ALK-positive lung cancer, because patients have lung cancer which is operable, but we've never bothered to check whether it's ALK-positive or not, because even if it was ALK-positive, we never used to do anything about it. But we now know that if you take a patient who's had operable lung cancer, a stage 1 or stage 2 or a stage 3, and if it's ALK-positive, then they should ideally have an ALK inhibitor after surgery to minimize their risk of relapse. This is a whole new disease. We don't understand the natural history of this disease. How's it going to play out? How are patients going to feel? How are they going to behave? How's the disease going to behave? We don't know, right? Let's learn together. Let's figure out what it means. And as I said, we've got whole new types of drug treatments coming through that we perhaps haven't even thought about at this stage. So I'm going to close with a quote from the one and only Nelson Mandela, who said, "It always seems impossible until it's done." And that, I think, is a real theme, because we always think we're against it, we're an uphill battle, and then we find a solution. And I think really, if we look at the story of ALK-positive lung cancer, it's always been a battle, then we found an amazing drug which has come in and then mopped it up, and we've been in a very good place. And with that, hopefully, you'll get to your dessert if you've not had it already. And I wish you all the very best for a very good conference. Thank you with all your attention. Thank you.